Mr. Chairman, sir, fellow colleagues, ladies and gentlemen. The topic for my presentation is a case-based presentation of VTE and DVT. We just heard the medical management of VTE, either a low molecular weight heparin or a fractionated heparin or a thrombolytic therapy or DTI. The patient came to us in emergency, 73-year-old male with syncopal episode followed by a fall in the bathroom and a sustained injury on the forehead. These were all his variables. We found that he had a significant degree of hypotension, his S2 was loud and JVP was raised, and we found his injury on the forehead as well as on the nasal bridge. EKG revealed a classical tachycardia with a dominance of the R wave in V1. So we thought clinically either we are dealing with a cardiogenic shock or a septicemic shock or ACS or got a hypovolemic shock. ABG revealed a significant degree of hypoxia, and the X-ray chest revealed a linear atelectasis in the right lower zone, and we subjected the patient to an echo evaluation, and we found there was a significant degree of tricuspid regurgitation with a RV volume overload, and we can see the shift of IVS towards the LV, and the RA was enlarged, and there was a mild degree of pericardial effusion. In the peristernal long axis view and the peristernal short axis view, we could document that there was a significant degree of dilatation of the pulmonary artery, and we could see there was an echogenic shadow lying at the level of the bifurcation in the transthoracic approach, suggestive of pulmonary embolism. We could see no evidence of DVT, but the flow state in the lower limb was low. All the variables of biochemistry was normal. His tropi was negative. What's the diagnosis? The diagnosis was acute pulmonary embolism. We subjected the patient for a BiPAP support. Before that, we thought we must do a CTPA. And we subjected the patient to IV fluids. Before that, we did a CT scan of the head because he fell down in the bathroom and there was no evidence of any hemorrhage. We subjected the patient to a thrombolysis, and that's how we managed by intravenous 10E active just a bolus of 50 milligrams in 5 seconds. In first hour, we found a minor bleeding through the nose and mouth. In 3 hours, there was a dramatic improvement in the hemodynamics and the clinical variables. In 6 hours, we discontinued iron drops. In 12 hours, we repeated an echo and we found significant reduction in the RA and the RV volume, and there was an increase in the cardiac output with a significant reduction of pulmonary artery pressure from almost 90 to 45. After 24 hours, we subjected the patient to the CT angio, and that's what we documented, that there was still a residual thrombus lying at the level of the bifurcation of the pulmonary artery. D-dimer was positive, FDP was more, BNP was slightly raised, antithrombin 3 was deficient in this patient. This is what we did after 4 weeks. There was a complete dissolution of the clot at the bifurcation of the artery. TNK is a new thrombolytic agent which is used in a lot of patients with pulmonary embolism. And the older agents which are approved by FDA are streptokinase, urokinase, or RTPA. TPA is a lot of data which has come up, which I'm going to show you in next few slides. TNK in the treatment of acute pulmonary embolism is shown in 2010 with a significant reduction of the morbidity and mortality by a significant improvement in the various variables which are shown here. In stable pulmonary embolism, 2009, it was shown that there is a significant reduction in the RV dimensions after we treat this patient with TNK if we compare it with the placebo. The same thing has been shown here in the graph, a significant reduction in 7 days' time in the RV diastolic dimensions. And we see here the bleeding tendency, minor bleeds are more in the TNK group as compared to placebo. The major bleeds are almost double than what we see. It's a case Pletho trial which was shown in the ACC last year, and this study was conducted in a number of countries, and 2007 to 2012, total 6 years, 1,000 patients, and the primary aim was to see the efficacy of TNK in intermediate risk pulmonary embolism and to assess the safety of TNK in patients with intermediate risk. This was the design of the study, and the number of patients, as I mentioned to you, were thousands, and this is showing very clearly that the all-cause mortality was lower in the TNK group as compared to the placebo group. This is just to show the hemodynamic collapse was lower in the TNK group as compared to the placebo. And we see here the recurrence of pulmonary embolism was very significantly lower in TNK group as compared to the placebo. All stroke, we can see here the prevalence rate was little higher as compared to the placebo because these patients who had a stroke were more than 75 years of age. All-cause mortality, as I mentioned to you, was lower in the TNK group as compared to placebo. And if you see here the data, age less than 75 years, the odds ratio was less than 1 in TNK group as compared to those who were more than 75 years of age. The efficacy versus safety according to the age, it was shown that the mortality and hemodynamic collapse was definitely lower in the TNK as compared to the placebo. The potential 10-year place, as I mentioned to you, we can give just in 5 seconds as compared to streptokinase or urokinase, no hypotension, no allergic reactions, longer half-life, rapid action. And we see here, it is purely weight adjusted, easily manageable bleeds, we are not to worry about it, pre-hospital thrombolysis or in the emergency, and if you compare TNK with STK, TNK is definitely superior. TNK, if you compare with the LT place, it is superior in many aspects. Anticoagulation, we manage our patient with the low molecular weight heparin. Risk stratification is must in every patient to see whether they are hypertensive, TROP-I positive or negative, and the RV dysfunction assessment. It's very important to categorize our patient to high risk or non-high risk, and non-high risk to intermediate high risk or a low risk. And this is what the algorithm we use. High risk patient, all are subjected to an echocardiographic evaluation. I want to emphasize here, echocardiographic evaluation is enough. CTPA is not required in every patient who are having hemodynamic collapse, as we did in our patient. Thrombolytic therapy should be used in patients with a high risk PE or intermediate risk PE presented with cardiogenic shock or a collapse. A non-high risk, we can treat only with anticoagulants. To conclude, ladies and gentlemen, thrombolytic therapy, especially TNK, is the agent of choice in hemodynamically unstable patient, whether they are massive pulmonary embolism or intermediate pulmonary embolism, and has a tremendous morbidity and mortality benefit as shown in the PLETHO trial. A need for national registry of TNK is a must in India. What's the take-home message? Life of millions is at stake. With PE and DVT, timely and effective intervention is the need of the hour. Thrombolytic therapy is the agent of choice for massive pulmonary embolism, and recently the data in intermediate pulmonary embolism. Lifelong treatment in thrombophilia with non-reversible risk factors. Where the risk factors are reversible, the treatment of anticoagulants is from 3 months to 6 months and maximum 1 year. What's the future direction? TNK is the answer. If you have to balance the various agents which are available before, there may not be any pulmonary embolism if we affect our patients very effectively with TNK. I won't go to the details because of paucity of time. I created a quiz here, but I would just like to show one slide and like to have your opinion of the house. This patient is a very young lady, 27-year-old female who was pregnant and was admitted in a hospital. And this is what we see the nuclear scan. 27-year-old pregnancy for the first time, a massive DVT in the common iliac vein, IVC, and we see in the femoral and as well as in the lower leg veins. And patient delivered. She was just on low molecular weight heparin, and they thought they are dealing only with the DVT. We subjected this patient she was discharged from that hospital and came to me for a follow-up, and we found this patient had 2 IVCs and a significant degree of anomalous veins in the abdomen, and there was only 1 kidney. And this patient, they were subjected to IVC filter. So I think this patient is coming to me for a regular follow-up, and we are just managing this patient with a low molecular weight heparin. I would like to have the opinion of the house, 27-year-old, single kidney with multiple thrombi all over in the anomalous veins system and 2 IVCs. How should we proceed to manage this patient? Thank you very much for a patient hearing.
Questions, please. Can we have microphones given to the speakers? Thank you.
Yeah, somebody wants.
I would wonder if she were hypercoagulable.
do a workup for hypercoagulability and see if she's got factor V Leiden or any one of the various things she could have.
She is antithrombin 3 deficient and she is protein S deficient
Right.
and she is single kidney. She is obese, metabolic syndrome, she is hypothyroid and she is a baby who's 6 months old now.
Chronic anticoagulation.
Beg your pardon?
Chronic therapeutic anticoagulation with Coumadin, one of the drugs.
She's just on Coumadin. We are giving about 6 to 8 milligrams per day. And she's taking it for the last 6 months. And we are going to subject her for another nuclear scan to see how much is the residual thrombi. She's still having swelling of both the legs. And she is symptomatic at times. She is ambulatory, but quite obese.
Right.
She was in.
Didn't have any pulmonary embolism in the past. So why an IVC filter was put?
This patient was admitted in another hospital in Delhi. While she was pregnant, she had episodes of breathlessness, and there was an evidence of micropulmonary emboli, and they wanted to put an IVC filter, but they did not evaluate the patient effectively. Double IVC, single kidney. If they could put in, God knows what could have happened. And she was very, very sick. She was very moribund. She stayed in the hospital almost for a month.
What about our homocysteine levels, Dr. Chopra? Homocysteine level? Homocysteine?
Homocysteine was not done.
Not done. I think you should do it. Maybe simple vitamin deficiency. Young lady, 27 years old. Is she vegetarian or non-vegetarian in India?
She's a non-vegetarian.
Oh, then chances are much less. And I think you should do it. I've come across cases like this with a simple thing, homocysteine, and putting them on vitamin, tablets, you
Yeah,
can see.
we put the patient already on folic acid. She is on folic acid at the moment. And the only problem is she has got an IVC and anomalous tributaries of veins and diffuse massive thrombi. The future outcome, what is going to be the future, that was my main point of discussion here. Thank you very much, sir. Thank you.
Thank you.